Cupid. A trial for a new male contraceptive product has been overwhelmed with interest, according to the lead investigator of the ADAM study. ADAM is a temporary contraceptive gel for men that needs to be reapplied after 2 years to maintain the desired effect. In a moment, you'll hear about how this method works and who it could be best suited for. But with so much interest in this trial, why hasn't the male contraceptive market grown like it has for women? And what does this say about how society views contraception and who should share in the responsibility of using it? Should we update our thinking? Dr. Yvonne Ong is a specialist GP working with Family Planning New South Wales, and she's on the phone this morning. Good morning, Dr. Ong.
Hi, thanks for having me.
No worries at all. So let's start with the basics. Can you help us understand how this new contraceptive method works?
Yeah, absolutely. So for my reading of the ADAM study, the hydrogel is a substance that is injected into the vas deferens, which is the tube that delivers sperm to meet the ejaculate. And the hydrogel hardens and blocks the sperm from being able to join with the rest of the ejaculate, thereby preventing unwanted pregnancies.
So it's a physical barrier that's stopping the sperm from combining with the semen during ejaculation. So what happens to the sperm that are blocked by this gel? Where do they go?
So the body does reabsorb it, so it doesn't backflow or cause any effects back at the test.
And what is known about the way in which the gel dissolves and obviously how that's absorbed into the body as well?
From what I've read about the gel, it is designed to dissolve at the 2-year mark, hence being a reversible option. I have read that they have, in animal studies, been able to dissolve the gel before that 2-year mark in order to provide that flexibility in hopes for when those with the gel want to fall pregnant.
But presumably if the gel dissolves naturally on its own, that's the desired outcome. There might be this period towards the end of the 2-year period. The efficacy of this gel might not be quite strong, and perhaps it's degrading at a rate that might allow some sperm to get through. Is that a consideration patients or people potentially considering this product should keep in mind?
Well, at the moment it's still in early stages, and the study that is going on in Melbourne is involving multiple semen analysis to try and determine if that gel dissolves faster than anticipated. But the primary reason why the study is taking place in Melbourne is to assess the safety of the gel long term.
Okay, that's a good segue into my next question. Obviously, what are the side effects of this product?
So from the readings that I've done, the gel is injected under a local anesthetic through the skin of the scrotum. And that's how the gel ends up in the vas deferens, which is the tube that delivers the sperm. And at any point where there is a break in the skin, we expect there to be pain and swelling at the site. However, we don't expect it to be as much as, say, a surgical cut. The other thing to remember whenever there is a break in the skin is that there is a risk of infection post-procedurally as well. Now, in terms of things beyond that, it is difficult to say whether there is a long-term adverse effects to do with the hydrogel staying in place for longer periods of time. We do know that the hydrogel is generally biostable and generally doesn't react, but this would be really the first study looking at how the hydrogel rests within the vas deferens itself for that period of time.
Based on your reading of this trial, the early results that we have, how would you go about advising someone whether or not this could be an option for them or perhaps they should discount it from the beginning? How would you go about giving someone advice in that regard?
In terms of whether they should or should not sign up for a clinical trial?
Yeah, say you're in a clinic and you're helping somebody and they present this idea to you, hey doc, I've heard about this, what do you think of it?
So I suppose in order to provide that sort of level of individualized advice, I'll need to do a bit more further study into the substances that are used in this trial, as well as what the ongoing monitoring requirements are. So in this instance, there will definitely be the need for frequent medical review for 3 years, as well as the need to be available to submit periodic semen analysis. So if you are unable to take part in those follow-up tests, then you may be putting yourself at risk should you, for instance, suffer an adverse effect 1 year down the line and you happen to be traveling overseas for an extended period of time and can't make your usual checkups. So the logistics of trial participation is one thing that I tend to counsel my clients about. But then, of course, secondly, it would depend on your individual health circumstances as well, whether you're fit and healthy and that you have the capacity to make informed decisions.
So it's obviously you need to be quite informed, you need to be quite committed to the process, quite rigorous with keeping your health, scrutinised and up to date. That's quite sensible, really. If someone's willing to take on this be involved in a trial of this description, yeah, of course you should check all your boxes, cross your T's and dot your I's. That's very sensible. So you bring up a good point, though. Obviously, it's an individualised case by case scenario if this is suitable for some person, or maybe it might not be. But this raises another question: how does the type of contraceptive change based on the dynamics in committed monogamous heterosexual relationships, the types of couples that you work with and whatnot? How do you change the advice that they need based on their individual relationship dynamics?
That's a really good question. The way that I generally approach it is I don't make any assumptions based on someone's marital status or relationship status. That actually most of the clients that come to family planning have some idea as to what they may want already. And what we do, our clinicians here, is that we provide a very open discussion, providing more information about the types of contraceptions that they are interested in, but also making sure that they are aware of every other option that is available out there. I think that, it's not our place as clinicians necessarily to dictate whether or not someone should be going for an option of contraception that is not reversible, in other words, permanent, versus something that is temporary or otherwise based on their life situation. It's really up to the individual to decide for themselves what's suitable.
And as you point out, the methods are different and obviously suitable for different stages of life. We understand that. Even the marketing for this trial product speaks about sharing the contraceptive burden responsibly, more equally between partners. You work at the forefront of this space, helping people make decisions about family planning and how to go about it safely. Do you see a lot of men champing at the bit to take up the contraceptive burden?
We have definitely seen an uptick in the number of men interested in exploring contraception. And since we started our vasectomy service, we have seen that increase in demand. And it's in proportionate to the Medicare data. So we know that in 2013 to 2014 financial year, Medicare did report assisting with funding vasectomies for 22,000. But then 10 years later, for 22-23 financial year, that increased from 22,000 to 38,000. So we have seen that increase in demand proportionate to national data.
Yeah, almost a doubling there from 16 to 38. That's adding an extra 16,000. Why do you think, when we sit back and peruse what's available in the pharmacy for contraception, a lot of brand names, a lot of products available for women, not as many available for men. Why do you think we haven't seen the market for male contraception expand with different options like we have for women?
That as well is a really good question. And there are very complex social circumstances, research climate changes, political climate changes over the last few decades. And certainly a big part of that potentially could be due to the, like you were saying, about the burden of responsibility laying with the women when it came to household tasks, and managing, things that are related to household and family once upon a time. But I feel anecdotally, and what I've observed in clinic, is that there's that increased engagement amongst males and men in terms of wanting to support women in making those decisions. And as well, I think that there's a level of trust, particularly at the beginning of relationships or in casual relationships, of relying on the female partner to be taking their contraception regularly, or if they are taking contraception or have an IUD or an implant in place, that some males prefer to have that added layer of security, knowing that they themselves are on a reliable and reversible form of contraception.
What do you think might be done to make the contraceptive product market more equitable?
I think that research such as the ADAM study is one step in the right direction. And I do know that there have been many different other forms of male contraception that have been explored over the years to varying degrees and success. I think that increased demand and awareness of the imbalance in the number of options available is always going to be helpful as well in terms of making decisions in that research funding space.
Just finally, Dr. Ong, the hydrogel is in the trial phase, and according to the manufacturer, it's expected to release its findings after the 3-year trial ends, which is at about 18 months away. What would you like to see in those results to indicate this method could be viable and successful on a mass scale?
Oh, absolutely. So firstly, safety first. So we want to make sure that long-term, over the 3 years of the study, that men are not experiencing pain with daily function, with sexual function, that there is an effectiveness, so that there is no viable sperm in those semen analysis, and of course that reversibility aspect of it as well.
Dr. Ong, it's been a pleasure to chat with you. Thanks so much for your time.
I really appreciate the opportunity.